I'd like to introduce myself. I'm John Fitzpatrick. I help organize these meetings. I have on in my private life. I have a small consulting practice in both digital health and also international strategic marketing. I like to go around the room sort of and have each person introduce themselves quickly, and then we'll get started on our presentations. First with the heavy technology group and their call solution, and then we'll look at Unite Us after that. So um, with that, let's kick off. Jennifer, if you want to go ahead and quickly introduce yourself, we'll go around the group.
Sure. Good morning. My name is Jennifer McGlothen. I'm Community Engagement Manager living right here in Kansas City with Unite Us Build Network. Thanks for having me.
Great. Welcome to the group. Stan.
I'm Stan Egovich. I'm retired young KC, still affiliated with young KC and KU, consultant, work with Heart to Heart some.
Steve Condon.
Well, I'm Steve Condon. I'm with Heavy Tech Group, and I'm here with Matt Atkins today to discuss a bit about some of what we do.
Great. Robert DeLeon.
Good morning. My name is Robert DeLeon, and I'm a community engagement manager with Unite Us, and I'm clear on the other side of the state in Garden City, but here to support Jennifer this morning.
Great. Matt.
Sorry, I couldn't remember the hotkey. Hi, everybody. I'm Matt Atkins. I'm the CEO of Heavy Tech Group. Steve and I are here today to give you a demo for what we've been working on and check everybody else's stuff out.
Great. Anurag?
Good morning, all. My name is Anurag Patel. I'm CEO of Helix Health. We do predictive analytics in primary care populations.
Thank you. Liz?
Hello, I'm Liz Cook. I'm the clinical telemedicine manager at Children's Mercy.
Jay?
Good morning. I'm Jay Edgar Bennett, with CEO of Join.
Thank you. Jessica?
Hello, I'm Jessica Hutton. I am a community engagement manager based in Wichita, Kansas.
Great.
With Unite Us.
Great. Dr. Farrell?
Hi, I am Diana Farrell. I work with Mark Clement in the diabetes clinic, and I'm currently a research scientist there.
Great. Thank you for coming. Dr. Gary?
Good morning. Keith Gary, Vice President, BioNexus KC.
Great. Beth?
Good morning, Beth Bartel. I'm also with Unite Us, and I'm over on the St. Louis side of Missouri.
Oh, welcome.
Thank you.
Craig?
Craig Christensen, H4 Technology, co-founder. We do data integration, SDOH solutions for behavioral health populations, hospital patients, and hospital systems. So, thanks.
John Birch?
Yeah, hi. I'm John Birch. I'm basically here as I'm a member of the Mid-America Angels.
Great. Thank you, John. Janine?
Good morning, Janine Gracie with the Heartland Telehealth Resource Center.
Great to have you, Janine. Thanks for coming. Robert Stiles. Robert Stiles, are you grabbing that cup of coffee? Robert is with KU, works in telehealth projects there, and as a program manager. Aaron
Deacon, Managing Director of KC Digital Drive. And I would invite people, if you would like, to rename yourself in the participant window so that people can see your organizational affiliation.
Great. Teresa?
Great. Good morning from sunny Florida.
Oh,
I'm
great.
Yes, getting ready to go out in the golf course.
All right.
Yes, so with Guardian Group, I do health IT consulting. So working with some of your organizations, trying to put together the integration of social determinants of health and clinical information, particularly focusing on Missouri, but also picking up Kansas. Thank you.
Great. Kelsey.
Hi, I'm Kelsey. I work with Liz Cook at Children's Mercy. I'm a telemedicine training coordinator.
Great. Welcome to the group. Robert Stiles, are you there with us? I guess he just had to step away. Is there anybody that I missed? Looks like we have one more coming in. Is that you, Rich?
Yes, it is. Sorry, I'm late.
No, that's okay. We were just in time for you to introduce yourself.
Rich Burry. I'm in Phoenix. I'm a little bit early in the morning for me. I do some healthcare consulting in Omaha. Supposed to be warm up there today, though, I hear.
Yeah, it is very nice. Beautiful sunny day here in Kansas City. So.
Good.
Well, with that, I'd like to turn it over to Steve Condon and Matt Atkins to give us a view of what Heavy Technology Group is doing. And I'm going to share the screen for multiple participants so you guys can go ahead and use it as you choose.
Thanks, Joe.
All right, thank you so much, John. All right, as John said, I'm Steve Condon. I'm CIO of Heavy Tech, and Matt Atkins here is CEO. We're a newer company, but we've been working with telemedicine recently in the last couple of years. We got into that kind of happenstance through our previous employer. We got a recommendation through a very nice partner of ours, and we've started developing software to support triage nurses, particularly those who are doing after hours, on call, and off hours services. So that being said, over the past year and a half, we've deployed a product called On Call Hub to help them do so, and we've onboarded a number of clients. Both small clients working from home, as well as a hospital system. So we're trying to service those who are kind of falling between the cracks a little bit, trying to get this kind of service from some of the more expensive providers, and also just trying to figure out what people need and kind of update their experience with telemedicine and the software that they use with it. So that being said, as I mentioned, On Call Hub is our current product. Matt and I have a number of years of experience in software development and architecture, and this is kind of our baby at the moment. So that being said, Matt, did you want to fire up a screen and let everybody see what we've been working on?
Sure thing. All right. First of all, can everybody hear me okay?
Yes, it's good.
All right. Can everybody see my screen now?
Yes, it's up.
Fantastic. All right. So this is On Call Hub, everybody. It's web-based software as a service. It is accessible from anywhere. It doesn't require you to install any kind of software on your local machine. Compatible with all modern browsers. Essentially, all of our customers have access to this. We don't do user-based licenses. So the triage nurses access this, the providers access this, the practice administrators access this. Everybody can get into this, and this is where all the fun happens. So what Steve and I are going to do for you today is just a quick demo of the high-level view of the process that's typically played out in On Call Hub. I'm not going to dig into any of the back-end stuff, how we put in any of the notes or on-call schedules or anything like that. We're just going to show you how a call comes in, gets worked by a nurse, and then how it gets shipped out to the practice. just to give you an idea of what we do. And then we'll talk a little bit about plans for the future afterwards. And kind of what Heavy Tech is looking to do in Kansas City. So I'm going to go ahead and log in. And I am going to, for the purposes of this demo, Steve is an answering service right now. He's going to change in a little while to a parent, but right now he's an answering service. So to set the stage, essentially pretend a parent has called a doctor after hours, say 8 o'clock. They call, obviously the office is closed. He's been redirected to an answering service. The answering service, has answered the phone, told him to call 911 if it's a real emergency, all this stuff, and then offers him, would you like to talk to a triage nurse? And Steve says, yeah, I would, because it's not quite a 911 emergency, but I would like to talk to a medical professional now. I'm kind of in uncharted waters for myself here. So the answering service says, okay, and takes some basic demographics from him, which again, Steve is the answering service for the purpose of where we are in the call right now. So Steve is entering some information right now and he just submitted it. So the answering service went in and put some basic demographics in for this call and then hit submit. And from there, I am logged in as the nurse. So for the purpose of this call, I am the healthcare professional. And I am watching this queue and I see, oh, look, a call just came in about a Sally Smith. She's 10 years old. Looks like she's having an asthma attack, must be pretty severe. Steve probably wouldn't have called me. He's probably been through this, since she's 10 years old. So I'm going to go ahead and go, okay, this is a call in my open queue. I'm going to check this out. I can see the demographic information that the answering service already put in for me. I can see the callback phone number, all that good stuff. So basically what I'm going to do here is assign this call to myself. That takes it out of the open queue. So the other nurses working tonight know that, this call is being taken care of. Administrators can come in and see that I'm working on this call. And what I'm going to do is basically pretend I'm calling Steve back right now on his callback phone number. And then I'm going to start working through the actual assessment down here with Steve. So when Steve put this in as the answering service, he can only see this demographic section of this form. And this entire form is customized for each one of our clients. So we have several triage providers. Each one of them have a different form. They all kind of generally follow along these lines. Any healthcare professionals on the line, you'll recognize all of this stuff. But they do change the flow of these and some of the things they record, especially people who are, ped-centric and things like that. So just keep that in mind, but we won't go too heavy into that right now. So I have called Steve back, and in this case, Steve is Jim Smith. We'll stop calling him Steve. Hi, Jim Smith.
Hello.
I understand your daughter's having an asthma attack. And again, everybody, I am not a triage nurse, so I don't know what the typical script for this would be. I just know how to use the software. But basically, I'm going to start by taking a look here. Because Steve, as an answering service, identified that Jim Smith is a patient of Dr. Charlie Brown at ABC Family Care. You can see here I've got some information that came up immediately when I started working on this call. We can see that ABC Family Care has an on-call provider right now who is covering the 6 to 6 shift, basically a 24-hour on-call shift. That's the on-call provider that ABC Family Care has identified for my triage service as the guy I should call if I have to talk to a doctor from that practice about this patient. It's an asthma attack. It's fairly straightforward. I don't think we're going to need to talk to Patty. We can also see down here that there's some other information that's been pre-entered for ABC Family Care. This is all, secondary protocols, other orders. You can see they've got a protocol for the ER. They want us to put some additional information or call the on-call doctor if that happens. You can see we've got a COVID protocol. The triage providers can add as many of these notes to this practice as they need. They can also add notes to the actual on-call providers. They can do all these things. We can also see down here that we had a previous call. That was just a test call we were doing earlier. So we've got a lot of information here already at our fingertips. This is a huge time saver for our clients. Typically, they would have all this information in a Word document somewhere, Dropbox, a spreadsheet, something like that. Here, it comes right up immediately when ABC Family Care is selected and when Dr. Charlie Brown is here. So I'm going to exit that mode and go back into triage nurse mode. We're going to work through this with Steve very quickly. And in this case, Steve is Jim Smith. So, okay, Jim, I understand that little Sally is having some issues breathing. I just need to collect some basic information from you. How much does Sally weigh?
65 pounds.
She's 65 pounds. Does she have a fever right now?
No, she does not.
Okay, so she's afebrile. What is her actual temperature?
98.4.
All right. That's looking good. So you already said she's having difficulty breathing. Is she slightly short of breath? Is she wheezing? Is she having like heavy difficulty breathing?
She's slightly short of breath.
Okay, we're gonna do slight short of breath. All right. Is she dehydrated at all? Has she been drinking normally today?
Yeah.
Okay. Does she have any allergies at all besides the asthma?
Seasonal allergies, hay fever.
Is she on any regular medications right now?
No.
Okay. Besides her rescue inhaler?
Correct. Sorry, I forgot about her albuterol.
That's okay, that's normal. People with sick kids forget things when we're on the phone with them. Does she have any other health history that might contribute to, her shortness of breath, or besides the asthma, of course?
No.
Okay. All right, so I'm gonna then work through a protocol with you, sir, and that's gonna help us decide what we need to do about Sally tonight. So, exiting my nurse triage mode, I'm gonna go back into demonstrator Matt mode here. This is Clear Triage, which is a piece of software provided by our partners that Steve mentioned earlier. This is basically just decision support software. It doesn't hold any kind of records or anything like that, but what it does is it takes the Schmidt-Thompson clinical protocols for telephonic nurse triage and provides them in a web accessible form for the users to be able to work through these. So basically, this provides a single sign-on for our users. We get a unique ID for every customer from Clear Triage. We associate that in On-Call Hub, and that's what allows us to do this one-click open of Clear Triage. And typically, Clear Triage and Heavy Tech Group work very closely as we're onboarding new customers and get all this set up for them. That's a very simple process. So basically, once we get into clinical protocol territory, the nurse has to move over here to Clear Triage to just work through these. And this is just a very simple web form. Like I said, it doesn't actually record anything. So the nurse would come in here and start looking for the protocol to use. In this case, it's an asthma attack. The P is for Pete here, and I'm probably going to butcher this part because, again, I am not a medical professional or an expert on protocols or this software. So we're just going to work through this quickly. Basically, once the nurse starts drilling through these, there's some more information here. I'm, confident. Obviously, this is an asthma attack. There's no other circumstances around this, so I'm going to go ahead and hit next. And then what I would do. And again, I'm probably going to butcher this part because I don't quite understand this process because I'm not a nurse. But what I'm going to do is kind of look through these and hit my first positive here and work from there with the father to really figure out what we need to do. And this protocol is going to kind of dictate the advice that I give as the triage nurse. So I'm going to go down here and Jim, when was the last time that Sally used her rescue inhaler?
About 45 minutes ago.
And when was the last time before that?
About 2 hours ago.
So are you doing it that frequently because she feels that she needs it? She can't breathe without it?
She feels like she needs it.
Okay, so we're gonna start somewhere in here and kind of look at, how often she's been hitting that inhaler. And we're kind of seeing this one right here is a likely candidate. Jim, has this asthma attack been going on for more than a day, more than 24 hours?
No, it set in about 8 hours ago.
Okay, so we're gonna keep going. Do you have a pulse oximeter in the home, Jim?
I do.
What is the reading on her if you put it on her?
92.
Okay, so she's pretty normal. And we're going to keep working through these. And we're going to end up probably around here, urgent home treatment. And I'm not going to keep, forcing Steve to be an actor or me, because I know we're not very good at it. So we're going to end up down here. We're going to do urgent home treatment with a follow-up call, moderate asthma symptoms, all this good stuff. And then the nurse would just hit next. She's got some options here to work through these and provide advice to the parent for home care. So, all of these things have information that can be provided. Clear Triage also gives the ability to actually just email or text, handouts on how to care for asthma. We see here we've got 2 options here. I'm just basically going to check the ones that we used today, so we're going to pretend that I gave all of this advice to Jim Smith. And then from here, all I do is hit copy. And that pulls the call notes into my clipboard where I can come back in. I'm just going to close Clear Triage. We're done there. And I can just paste them right into this protocol field here. So this creates a definitive record of everything I did when I was working the protocol. I can also do, since this is just a text record, I can modify this as needed. And that happens pretty regularly because they don't always give the exact same advice that Clear Triage gives. And the nurses do have that discretion. So from there, we're done with Clear Triage. We're just going to go down here to the closing statement. The caller agrees with advice and all that good stuff. I am the nurse who took care of this call. From there, I can do some tagging on the calls. This is basically for just organizing the calls and pulling them together for some reporting we do. So I'm going to go ahead and say, we gave home care on this one. And I'm going to advise Jim Smith to call his doctor in the morning, follow this home care, and I'm just going to hit save. And now that call is basically all done. So you can see down here, we filled all this information out. But from here, it's still sitting with me. It's still assigned to me. What I'm going to go ahead and do is just hit send to practice. I'm going to confirm that. So now the record has been sent to the actual practice, ABC Family Care. And our practices have a ton of different ways they consume this information. The guiding principle there is flexibility, because those offices are so different in their preferences. We have the ability to fax, because a lot of offices still like faxing for some reason. We have the ability to let them log in. That's our preferred way, basically, because like I said before, we don't do per seat, per user licensing. The triage companies have the ability to add as many users for the practices as they'd like, and we encourage them to come directly into On-Call Hub and get the record for themselves. So if a practice came in and logged in, they would have a very similar front page. It's just a list of calls that came in the night before, and they can come in here, they can print it, they can save it as a PDF. They can do basically what we just did with Clear Triage and copy the entire call record out to their clipboard and then paste it into their EMR. This is very typical for people who use like Epic or Cerner. They would create a phone encounter for that patient and then copy paste this entire record in. Or like I said, they can receive it as a fax as well. So we have practices that do it all different ways, and that's how they consume that information. Now there's a lot more to this. There's a lot more to the whole system, but that's the basic overview of what gets done in the system every day, day in, day out. We have so far, I think, processed about 150,000 of these calls.
180,000.
History. What was that, Steve?
180,000.
180,000 of these calls. We are servicing these calls, every day, like I just said. And so far, everybody is loving it. So future plans for this system are to further integrate the communications stack, basically. You saw Steve was operating as an answering service. That's a little bit of an air gap because answering services typically have their own systems and all those things. And even though he was one that logged in and input the call directly into On-Call Hub, which is typically how they do it, we have some of them that don't like doing that. So we're working on ways to automate the phone system as well. We also have clients who don't use answering services, period. So they use kind of third-party VoIP providers and a whole mishmash of technologies. We're trying to consolidate all that, incorporate it directly into On-Call Hub so that On-Call Hub can be a turnkey solution for nurse triage. Basically, you sign up with us, you have everything you need. You've got your phone line, you've got the ability to send secure messaging, you've got the ability to have patients even come to you through secure messaging and basically have a text message conversation with the nurse instead of, having to pick up the phone. So we've got a lot of plans for exciting communications features like that. And currently what we're doing as far as the KC area is looking for kind of development partners, meaning doctors and triage companies to work with us to help develop the software to better fit the KC market. Because right now it's a little bit different, I think, than how KC does business. But we're working through that and trying to find local partners. Right now, everybody we service is very disparate, kind of spread out over the East Coast. We've got customers in Texas and in some of the northern states. Any questions on what everybody saw today? Feedback, don't be afraid to call our baby ugly, as Steve always says. We are open to any and all feedback. Our primary goal with this software is just to make better healthcare software. I like to ask people, when's the last time you walked into your doctor's office? Talk to your doctor while, every doctor has a workstation or a laptop or tablet at this point sitting in the office. And I always ask everybody I know, when's the last time you walked into your doctor's office and looked at that screen while they're typing on it and said, boy, that looks like software I would like to use every day. And everyone laughs at that pretty hard. So our objective is that, to get to the reverse of that, to have somebody look at that and go, wow, that looks cool. That looks like software I would enjoy using. So that's kind of our guiding principle. We're kind of like the anti-healthcare software. We don't charge giant setup fees. We don't charge even really monthly support. We are completely different in all of those regards. So with that, I'll open it up again for questions and feedback. I appreciate everybody's time for sitting through Steve and I being very poor actors.
No, that's great. Thank you very much, Matt. I have just one quick question. In your future plans, do you see tighter integration with the EHRs and so on?
Yeah, absolutely. That's something that comes up in most, if not all, of our discussions with potential and existing clients is, what's next as far as integration. And that's exactly what we're looking at right now. A lot of people use Epic, for example. I mean, I'm sure a lot of people in this room right now are either using it or have used it. So that's obviously a target. Like, what can we do there to provide? So we're right now identifying what our major market is asking for and what they need specifically too, because it seems like everybody's kind of using it differently. Some people are almost like replacing everything they do with Epic, and then some people are just using it for a very specific purpose. So that is definitely on the roadmap here.
Okay, great. Others in the team, other questions for Heavy Technology Group? Teresa, you usually have a good one.
Sure, I'll throw one out there.
Yes.
Let's see. So let me come online here. Yeah, so on developing partners, what would be kind of the ideal characteristics for a developing partner?
It really could be anyone at this stage in the game. Like Steve said, we serve group homes. We serve, and when I say we serve, they're through a proxy essentially. We work directly with the triage providers. So probably the ideal partner would be a triage provider. So that would be probably the best bet. But at this point, we are also looking for practices, healthcare groups who provide triage lines. We are looking for, like I just said, we do a lot of work with group homes and senior care homes in kind of the New England area. They use our service to communicate with their triage providers to basically supplement their nursing staff because they can't have nurses at every location. So those are always good customers. We're basically looking for anyone, anywhere in kind of, if you envision the process of the triage provider from the patient all the way through the answering service, through the triage provider, through the practice or group home or hospital or healthcare group. We're looking for people in all steps of those stages to kind of work with us and be the ones that we can look over their shoulder and really see how they're using the software and what they really need. Because it's very difficult to, it's actually even hard to get feedback from our current customers. Steve and I call it Stockholm Syndrome. Everybody expects, not even healthcare software, just these days software in general, to be so bad that they won't give you feedback on the things that Steve and I really look for. They just go, oh, I guess this software kind of is not good too, and I'll just power through this. So it's a little tough to get that feedback. And what we found is you really have to have somebody who's willing to let you kind of just watch them work. So do a screen share, watch them go through their process and go, wait. Why did you click there? Why did you click here? Why did you type in the time that way? We've actually asked that question before. So a lot of things, it's difficult to just call somebody up and go, okay, tell me how to write software that does your job for you, right? Because number one, they're so used to software just kind of being a pain that they ignore things that are painful. And number two, it's all muscle memory for them. How often do you sit down and think about what you do day in and day out, communicate it to other people? So that's a very good question, Teresa. We're looking for triage providers of any stripe, whether they be associated with a healthcare group or they're a private company. A lot of them have popped up in the last few years. We talked to a lot of them. They like us because we don't have the giant setup fees that are typically associated with healthcare software, and they're just getting started. So, a $20,000 outlay when you're just getting started is a huge deal. And we also are looking for, doctors and nurses who work at practices and are looking to refine the triage process from their end.
I think to add a little bit to what Matt was just saying as well, I think one of the factors we're looking for as well, as enthusiasm, are just people who feel like their business may not, they may not be ready to sink that cost of like $20,000 into an existing software solution, and they don't think they have any options. We may be a good fit for them, so we may be able to help them, bridge that gap a little bit and provide them something that's more than affordable.
Okay, great. Any other questions from the team? This has been a very strong demonstration, guys. Thank you very much. If you would maybe, for the benefit of the team, put your website and contact information in the general chat, that would be great.
Absolutely.
Sure. Thanks very much, John, and thanks again to everyone else for your time today.
Yeah, thank you so much. Thanks for having us.
It was great to have you guys. Thank you. Well, then I'd like to introduce Jennifer McGlothen again for a discussion on Unite Us. I won't prejudice the nature of the solution by trying to give it my own title. I'll let Jennifer do that because I know that in this space there's a lot of different kinds of branding going on, and I invite you, Jennifer, to help us along that path.
Will do. I'll do the best that I can. I'm going to share my screen. And I'll introduce myself again. My name is Jennifer McGlothen. I'm in community engagement in the Kansas City metro area. And I am working with a team of people to build Unite Kansas and Unite Missouri, which is a statewide community information exchange. And also it's actually part of a regional exchange supported by Sync Health, our partner in this work to connect health and social services.
Jennifer, sorry to interrupt. Could you say a little bit more about Sync Health, or is that part of the presentation?
Sure, it's going to come up.
Okay, that's fine. Thank you.
I definitely will. This is an overview of what I wanted to talk about today. So thank you again to KC Digital Drive, Aaron, Leslie, and John for reviewing our information to invite us to present. And this is why we do what we do. I know that you're familiar with social determinants of health. 80% of health happens in the community. And to be able to do this work of connecting health and social services in the community, it takes a team. This is our team in Kansas and Missouri, and several of them are on the call with me today. We all work together and we live in our communities, support our communities, try to put ourselves in a position to contribute to our communities in terms of conversation, being involved in the work, and really looking for opportunities how we can complement the work and understand existing work. And I wanted to share our high-level vision. We are really focused every day on building on resource directories. And around the country, we do have partnerships with many United Ways and 211s to be able to do this work. And what we're looking to do, again, is build on that to utilize the Unite Us platform as an operating system, as public infrastructure to be able to coordinate care and connect individuals to care and resources more quickly, removing barriers, and then the ability to collect data from that point. Every piece of data that is entered in the system, of course, is a piece of data that we can then pull out at both an organizational level and an aggregate network level to be able to have conversations about gaps analysis, funding, program impact, who's being served, where they're being served, how they're being served, et cetera. And then work with the healthcare system to help invest in social services. And by doing that, we hope that we are contributing to systems transformation in that, again, we're integrating social services, that 80% of healthcare, into healthcare and reaching more people, connecting more people, and having fewer people fall through the cracks. And also an important piece is creating equity in our communities. Unite Us began in 2013 with two veterans who were transitioning from the military, and they experienced some fragmentation in our healthcare delivery system. That frustration drove them to find a solution. The solution was Unite Us. And since that time, 2013, we are currently working in over 60 counties around the country, over 42 states. We value partnerships, again, many partnerships to make this work happen in individual communities, 211s, healthcare providers, payers, and of course, community-based organizations, which is what myself and my team members are focusing on. Sync Health, you asked about Sync Health. Sync Health is a regional health information exchange. They are rebranded from NEHI, Nebraska Health Information Initiative, and they merged with Iowa Health Information Network to form Sync Health. And I do believe that there are continuing conversations so that they continue to increase their regional footprint in, I think it's 9 or 10 states now. And of course, Kansas and Missouri are included in that regional footprint. Sync Health has partnered with us in this work. They have a commitment to collecting and gathering and sharing health information towards improving health outcomes. Their support is for regional catalyzation, helping us to optimize networks, helping us to connect community-based organizations as well as healthcare providers and payers, and support and growth of the platform. And so as we move forward in this, again, their support means that community-based organizations have access to the Unite Us platform at no charge. When there are billable services within a community-based organization, there could be a charge associated with a data sharing agreement. And that happens with a conversation with Sync Health to determine that. But for the most part, community-based organizations that are not billing have access to the Unite platform at no charge. So that's a bit about Sync Health. I wanted to share with you our rollout in terms of this statewide effort in Kansas and Missouri. We launched in 10 counties, 5 in Kansas and 5 in Missouri in January, and we're continuing to do that work with lots of meetings, lots of conversations with organizations, and then moving on to workflow and planning and training with an April launch planned. I'll share that to date, we have had a lot of interest and are talking with many organizations. We have already begun to sign them up for participation. It's a really easy process. And we move forward and we'll continue to launch these networks throughout the state of Kansas and Missouri into 2021 and 2022. And you know, we really rely on the expertise of our partners, but our goal is simply to contribute to helping improve coordination of care for individuals in communities. And the platform is very, very easy to use. It's very flexible. I didn't plan to do a demo today, but I think I'm going to have time to show you a brief overview of it if we have time, but we'll move on and I will show you some main features about it. But again, we want to be able to strengthen existing relationships in the community and just work together with organizations to serve shared clients. In terms of a referral process or a referral workflow, this is what we are approaching by utilizing the platform. If Tom shows up at Sue's organization and Sue is doing some screening and identify that Tom has needs, she simply logs into the Unite Us platform, collects Tom's consent, and that's a very easy process that I'll talk about shortly. And that consent says that Tom is agreeing to share his information in the network. Sue then can send referrals to individual organizations for specific referrals that meet multiple needs within the system. And then Sue receives real-time data, and this is where we're talking about the data that is generated through all of this activity happening in the system. And so with this referral workflow, we're able to, number one, take some of the responsibility off of clients, individuals, families who are trying to figure out how to connect to resources. We take some of that responsibility off of them to be able to do that as providers. Secondly, the providers are able to see outside their own organizations, and we are able to eliminate some of the siloing that sometimes happens in communities. Organizations are able to see that client journey and again, work together to serve these clients. And then can't emphasize enough the data that we're collecting that can give us pictures of the community in terms of our services and where we need to perhaps make changes to continue to serve more people. So as far as overview of that referral process, we are able to share information between organizations because of our security and compliance. The Unite Us technology platform is HIPAA, FERPA 42 CFR Part 2 compliant. So we've covered those bases. Through the eligibility, all of the program information for organizations being visible in the system, we're able to match clients to organizations as opposed to them having to search for resources that are fit for their needs. We are capturing the consent one time in the system. However, that does not replace any consent that is happening at the organizational level, but it's simply a one-time consent that the client is sharing information, is agreeing to share information in the network. And I mentioned how important it is that we can now see the client journey as providers, and then the tracking of data and having this data that is structured, and we have shared metrics to be able to work together towards improvement of health outcomes. And again, I can't emphasize privacy and security and compliance enough. Just a review in terms of the technical infrastructure of the Unite Us platform. There are viewing permissions, user roles from the network level to the organization level to the program level, to be able to restrict information with users that don't need to see it. Relative to sensitive organizations or sensitive service types like domestic violence or interpersonal violence, we have even more heightened viewing restrictions so that only the people that need to see this kind of data can see it. I spoke about consent. When you log into the platform with 3 pieces of information, you can create a referral. And the last step before that referral is sent is to collect consent from the client. That can be done in 6 ways: client email, client smartphone. If the client happens to be with you, there's an on-screen consent. Also, the traditional downloading of a form and uploading it, and we have that available in 20 languages. An audio file is also an option, and the most popular one these days is called attestation, where the user in the platform simply reads a script to the client and they answer a specific set of questions, yes or no. The case manager or the user then signs their name on screen and click attest, and that is done and the referral is sent. I did want to mention that Unite Us has a very focused role on around equity and a lens on equity. There's a number of ways that we do that. Number one, as community engagement managers, again, we are invested in our communities. We really work to find and identify organizations that may not have this kind of a tool, that may be grassroots organizations that are doing awesome work in the community, that we can work with them to access this tool and make sure that populations can get connected. And sometimes that comes in the way of churches or places of worship, barbershops, things like that. Additionally, with regard to data, I just wanted to share this. This is a picture, and the title and the headline really speaks for itself. But this is network data that was collected from the St. Louis network that is distributing and tracking CARES Act funding for eviction. And so that data includes demographics as well as referral and outcomes needs. And so women of color have had a disproportionate impact on COVID and eviction, increased risk of eviction. So that is one of the ways that we also focus on equity, is working with organizations to be able to look at populations and really see what's happening and have the actual data to document and show the pictures that we definitely know are taking place. With regard to the platform itself and the data, there are organizational data that you have access to and can export through the platform in terms of a CSV file, and then being able to convert that information to a spreadsheet. And I mentioned organizational data that is very visual in terms of service types, client demographics, all of the information at an aggregate network level that is available as well. So with that, I didn't start my clock, but I think we're doing okay on time. There is our information. Myself, as well as Jessica Hutton in Wichita, we're both working together, as well as a whole team, on this effort in the KC metro area. And if you know of programs or organizations. Yes, Laura? Was there a question?
Oh, no, I'm so sorry.
That's okay. All right. If you visit Kansas and Unite Missouri websites, you will find our events. I mentioned that we're having meetings throughout the month of March before we launch in April. So you can certainly attend one of our community meetings and presentations to get more information, and also to see a high-level demo of the platform. We do a lot of one-on-ones with organizations to also discuss this opportunity and work through it, to talk about workflow and how the system can be used within organizations. And so that is my presentation. Let me know what questions you have, and if you would like, and if we have time, I'm happy to show you the software itself.
Yeah, that might be very interesting, Jennifer. Thank you very much.
All right.
What is on this screen that you have, the one that you just had, there's a link for join. What do you mean by join?
Oh, that's simply saying that I am ready to join the network, and you complete a form and let us know about your programming, and we configure your organization in the system. So that's what I mean by joining.
Okay. Does an organization need to be responsible for keeping you updated, or is there kind of a proactive method of updating the resource database?
Most organizations are pretty proactive because they have the capability. For example, if a program is out of funding or if they've reached capacity, they can go in and turn referrals off. As well, we work with network health team to monitor and make sure that information is updated. And then, for example, if an organization rejects a referral, which is completely fine, that's another way that we can also make sure that they are receiving quality referrals by keeping their information updated so that people can see the eligibility. But yeah, that's a voluntary process as well as one that we monitor.
Okay. So if someone refuses, it might be that they're assuming that they either don't have the capacity to handle the person, or there may be the wrong place for the person to be going at that time.
Yeah, it could just be a wrong fit. They feel that they can't adequately serve the client, but then they have the capability to forward that on to another organization. And for example, if there is a rejection, the sending organization can see that, and they would also be able to get involved to make sure that they get that client connected.
Okay. Other
Anybody
questions
else?
from the team? Yes, that's great. Thanks.
So Jennifer, this is Keith Gary from BioNexus KC. I wanted to make you aware of an initiative here called the Quality and Value Innovation Consortium that is led by Stacy Farr and John Spurtis, St. Luke's and University of Missouri, Kansas City. They're really taking on some quality and innovation projects within the Kansas City area that involve a number of hospital systems. And so a platform like this for communication and referral would be, I would think, highly valuable. So I'd love to send you an email with some information and connect you with those folks.
I would love for you to do that. Thank you. Thank you.
Question, did you mention, and I missed it, your funding model? How's this being supported?
Our customer is actually Sync Health. So again, we work with Sync Health, which is a health information exchange, and their funding is where the revenue is available. And we are committed to sustainability of that model. It may not always, well, I'll just say that there could be additional partners going forward other than Sync Health, but our model is that community-based organizations not pay for this system.
So you have an HIE that's supporting you. Where is that located? I'm confused.
They're in Nebraska. They began in Nebraska. It's called Sync Health, but it was Nebraska Health Information Initiative, and they have merged with Iowa Health Information Initiative. And so that is Sync Health. And I guess you may be wondering why Missouri, why Kansas? I believe that health information exchanges in general are looking to have a larger footprint so that they can expand services to their members in terms of the data collection that they do, and also to round out and complete a holistic picture of patient information by including social services. So that's essentially their interest.
Yeah, this makes complete sense within the HIE world, the concept, but who's gonna, they're willing to pay for you to work in the Kansas City area, or they expect Kansas City to pay for itself, or how does that work?
Yes, they are also, their support includes the Unite Kansas, Unite Missouri. We are also in Iowa, Nebraska, North Dakota, South Dakota. So I believe it's Team, you might be able to correct me if I'm wrong. I believe it's 9 or 10 states that they are investing in this work.
Really? Very
Yes.
interesting. Thank you.
Mm-hmm.
Yeah, this is Teresa. So Jennifer, thank you for joining our interoperability roundtables with Jake. So that's been very helpful to get the SDOH platforms kind of talking with each other, as well as then with the United Ways. And so it was great to see at the national level, the ONC is coming out with, lessening the privacy rules so that information can be shared between social services organizations and, more traditional health settings. Beth, you might talk about, if you could, kind of what's going on in St. Louis with the Community Information Exchange over there and United Way of Greater St. Louis, because that might give us some a model, at least, to kind of look at here for Kansas City.
So I would say that I can kind of speak to it a little bit, but I am pretty new. Mindy Allison is our team member who's really been integrated with the work in St. Louis. I will actually kind of, as we grow, I will start looking at the other parts of St. Louis, excluding Kansas City and St. Louis. But yeah, United Way has been an integral part, and it's a kind of a different thing. So from my understanding, St. Louis is kind of unique from what the rest of Missouri is going to look like with this, but we have been working really closely with United Way, and I know we're wanting to broaden that across both states with the involvement. And so I think the funding with the St. Louis region is a little bit different, but yeah, they are involved, and we are hoping to kind of get that across the board. And like Jennifer was saying, Sync Health is our primary funder at this point, but she also said we are trying to make this something that's at no cost for our community-based organizations. However, we do have a slightly different path that we take when we start getting into that healthcare realm of people who are getting involved. And again, Jennifer and Jessica could probably speak to that a little bit more in depth, because again, I'm like just shy of a month on the job. but yeah, I think that ideally, like we want to just grow across the whole way there.
Okay, welcome. Thank you.
Thanks, Beth. I guess I could share a little bit in that in St. Louis, the drive to adopt technology was really driven by the community, and they began in 2016. United Way of Greater St. Louis and the community, a cross sector of organizations, were really looking to be able to work together because they recognized that they were serving a lot of the shared clients, but they weren't really able to talk to one another efficiently. So they created the St. Louis Community Information Exchange. So that exchange includes United Way as well as many other organizations in the community. And they spent time evaluating systems for this work of connecting people to services and chose Unite Us. And so that was, I believe, prior to our work with Sync Health. And so as that work moved forward in St. Louis, they actually, once the pandemic hit, it kind of put not a bump in the road, but caused a pivot. And they decided to use the system for the CARES Act funding with what's called a rapid response network, so that agencies could work in the system to track those clients and that funding. And so again, that began in August, but just this past month, that whole network is continuing to expand beyond the eviction programming assistance to include many other organizations. It's about the Rapid Response Network was about 30 or 40 organizations, and now we have 30 or 40 more that have joined to include all of these other services in that network in I believe a 4 or 5 county area. And so that will be the exchange. And then outside of the area, as Beth mentioned, we'll be working with Sync Health to expand networks. Beth's going to be working, especially in Joplin. There's a Freeman Health System down there is super interested in working with us, and we're moving forward with that. So hopefully that's helpful. It gives you a little background on St. Louis and how they moved forward.
Thank you, Jennifer. John Birch, do you have a question?
Yeah, thank you. Yeah, Jennifer, this is really very interesting, and I'm very impressed at what you're doing, and it certainly is something that needs doing and is worth doing. I have a question that's semi-technology in nature.
Mm-hmm.
how do you relate to patients that are keeping their own personal health records? Even if it's just on Apple's Health Records app, they still have a fair amount of, a lot of people do, increasingly numbers these days have their own health data, or at least downloads from their hospitals and caregivers. Do you relate to that? Can you use that information, and can you provide information to that?
We don't actively have a product for that space in terms of a consumer facing or a patient facing application or portal to be able to have consumers or patients interact with the system. I know that it's being talked about, but as far as the Unite Us platform today, it is simply a platform whereby providers register to participate and enter their programming and work back and forth with one another to connect to clients. The client is responsible to say, I'm willing to share my information within this network. And again, that doesn't replace any other consents at the organizations that are working with this client. And then the only other touch point relative to back and forth between the client is through the case in the system in terms of the referral. When it's sent, they are contacted and can choose to be contacted via messaging or automated notifications about their specific referral.
I wasn't really thinking of this as being a consumer-facing communication necessarily, just that their ability to share the data that is on their phone with whatever caregiver you're helping them connect with.
So Jennifer, I'm wondering, because part of this is that there are different types of assessments, like let's say, depending on the situation that they're in and how they're entering into the network. It's possible, I believe, because we have it set up where, we kind of get some basic things, and it's very open-ended in the fact that, clients can share as much or as little as they want with the providers. And so I'm almost wondering, and again, if this is answering your question, if we were able to build something in, and again, depending on what provider they were working with in the moment, because you're right, like if they're recording their blood pressure, or monitoring that in their Apple Health app or something, and they wanted that information that was pertinent to their situation, are you asking if there's a way to include it so that it's there?
Well, the health record
others
app,
to see if they needed it, or what?
The health record app I'm referring to is the one in which they have already downloaded their information from multiple doctors and hospitals that they may have gone to.
Gotcha. Okay.
In which case, if you were to plug into that data as well as the data that's in the HIEs, you're getting redundant data, and that's must be unbelievably confusing.
I get that. There is, we haven't been in conversation specifically about that relative to what we're doing in Unite Missouri and Unite Kansas right now, but I do know that Sync Health is looking to have, and we will have, their master patient index that will populate our system, so that when someone logs into the system and tries to create a referral with those three pieces of information, first name, last name, and date of birth, if they have filled a prescription or whatever the case may be, and there's a record through Sync Health and that master patient index, it will be there.
Thank you.
Does that help?
Yes, it's a concern.
Thank you.
You said that's a concern?
Well, I think personal health records are, the new rules from ONC and CMS are going to stimulate the development of a lot of personal health record apps. And how they're going to fit into the current ecosystem is not at all clear.
Oh, I certainly agree with you. Conversation the other day with United Way as we move towards this work and the other thing I was thinking of is, for example, in St. Louis, in applying for different type of funding, I know they were talking about if a client or patient fills out a form and getting that into the system, there are definitely questions about where that information goes, and with the sharing of it, making sure that all the bases are covered relative to security and compliance and privacy. So I agree, and people are aware of that. And we as a company are very aware of that. I mean, we are committed to aligning with best practices relative to privacy and compliance. And so I do know those conversations are happening because I was a part of one. So I understand that concern, is what I'm saying.
Diana, did you have a question?
Yes, I do. And so actually I want to ask what you have for the pediatric population specifically, and what is the way that we might be able to also contribute to your registry. We actually have a data warehouse that include electronic medical record as well as wearable devices. So just to talk about what John say about personal health. Actually, our warehouse is integrating every single medical device that the patient have on.
Mm-hmm.
And so we actually building an infrastructure that will provide us the ability to provide their identified data with the precision of the minutes. So we can see activity level, what they're eating, what is their glucose in their blood. We see, for example, how they're sleeping, and then so on and so on. So I'm wondering if you have the capability to compare pediatric population across Missouri and Kansas City, and if it would be possible to have some kind of comparison metrics to see how we're doing while offering and covering the needs on our 11 clinics.
Okay. With regard to pediatric populations and privacy, I can say, because we work with school districts, that is dictated primarily by the state. Keep in mind, our system is a tool, and the consent that we're collecting, whether it's for a minor or whoever it is based on sharing information just within that network. So anything that organizations are required to do relative to security and compliance for their clients and their populations within the organization and based on state requirements, we don't change any of that. With regard to data for any population, that's going to be based on the organizations that are participating in the network. So as we build and as we grow, as long as that data is entered in terms of demographic data, then it's going to be there. We also have some tools whereby we can offer some customization. That is not part of the standard access to the platform in terms of anything outside of what's collected by organizations. Anybody else on my team? First of all, did that help a bit?
Diana?
I think that, for our side, we would be able to ship data packages that are completely HIPAA compliant, because we strip out everything that can, be defined by the patient. And when the patient upload or give our data, we already went through the compliance. So CMH, Children's Mercy is really good on that. So everything has been already pre-designed. And now our warehouse is already up and running. We're finishing the last steps to work together with our collaborators. So my thinking was because we are really interested in such a determinant of health, we are really starting incorporating some. And we have a couple of collaborators that are trying to give us, flat file with those values to integrate in the warehouse.
Oh, okay.
I'm wondering if we can, have data packages and maybe establish a collaboration in which you can give us some comparison metrics and see, okay, in your pediatric population, this is our value and this is what we see around you. So we can establish if every intervention that address specific situation is actually really working or not in the context of program that we are activating an intervention that are specifically covering social needs. Does that make sense?
Yeah, it does. I think that that would be something where we would have to start, first of all, looking at what your electronic health record is. We do integrate with Epic, and the Unite Us platform sort of, I'm not sure the right terminology, Teresa, you might be able to help me on this, but our platform sits, they log in through the Epic platform. And so there would be some sort of an integration required and some probably customized work with us to be able to accomplish what you're speaking to.
Yeah, maybe we can get in touch and maybe we can also talk this a little bit more. Thank you for having me today. This is really great for me to get to know what is around me, actually.
Sure.
And, you know, we can have a conversation with also the diabetes clinic director, Dr. McClement, and see our infrastructure that is completely cloud computing. We can, you know, overcome any Cerner or Epic's, you know, step point, because basically we are pushing the data from Cerner to our server and our top clustering. And from the clustering, then we have a series of steps in which we are processing all the data. Therefore, the final results is a full vision of the patient, independently of what they are using. And we really want to have such a determinant of health there, because we think that it is important to see those together with everything else that might be, you know, personal health records from the Apple device or Garmin device data, whatever they have, more information they have, better is for us to do a data-assisted decision making from the clinician perspective.
Right.
So I will post you my email and feel welcome to, you know, drop me an email. And thank you again for having me today. This has been great and I'm learning a lot.
Dana. What we'll look to do is have a conversation, and I'll include our network development team, and we can go from there. There's plenty of resources within Unite Us to be able to discuss what you're looking to do and figure out how we can support that.
Great. Thank you very much, Jennifer. Diana, it was a great review of your current work. It's very complex, and look forward to seeing something possibly happen there. Do we have any other questions from the team? Well, we do have a little bit of extra time, probably about 10 minutes. We do have a couple of announcements to cover at the end of the meeting, so we want to leave just a couple of minutes before 10, but are you able to take about 10 minutes to show anything from the demonstration perspective, Jennifer?
Oh, sure. Yep, I can do that. 1 second.
Not to put you under pressure. You don't have to do so. We can end early if.
No, I can show you a couple of things. Let me just get it ready. I'm going to log. Well, I'll just show you my login here.
Okay.
Okay, can you see that?
Yes.
You would simply log in with an email and a password, but I have to go into my iPassword here to get these out. So if I log in as Alicia Covington at Kansas City Food Pantry, for example, and enter my password, I am into the platform. It is web-based. There's no requirement for downloading anything. This is the homepage that you would be brought to when utilizing the system. The Unite Us logo always brings you back to the homepage. I'll share about these parts of the system in a sec. I'm logged in as Alicia Covington. Here are user settings for email, password, etc. Here is where she could let the system know what kind of notifications she wants as far as referral activity and things that need attention. So there's no need to stay logged into the system. There are settings that can be changed relative to notifications. As an admin, Alicia can see the users at the organization. She can see, here's where I was talking about programming. When an organization joins Unite Us, the form that they complete is what populates this information. So they have control over editing programs, whether or not their programs are receiving referrals or not. So that can be edited. and then the organizational profile. It's a little bit about that. Over here, the question mark, you can access the support as well as the chat function for the platform. This is a summary panel for the organization and clients that they are involved with. It shows that I have 11 incoming new referrals and 6 open cases. This is a chronological timeline of activity with the clients that this organization is working with. So if I look at my referrals, I can see them here from where they are received and what they were for. This is the dashboard. Any red dot is going to indicate where action is needed. But for the most part, I'm going to go back and just show you how easy it is to create a referral. I would click the plus button here, new referral with 3 pieces of information. I'll just say Jackson Boyd. His birth date is 07/08/1972. And this is where we'd search the records to see if we have an existing record for Jackson. And we do not, so we're directed to create this profile for Jackson. Here is where we're beginning to collect this demographic data. Red asterisk, of course, means that it is required, but it's defaulting to undisclosed. If there's a situation where the client doesn't want to provide that info, or if you don't have it, it's perfectly fine to leave it at this status. But again, that means that we would be minus this data on the back end. Jackson's email. And so this is where the communication happens, and Jackson agrees to receive messages at this email and automated notifications about his referral. We can click those. I'm going to enter a phone number. We can indicate when Jackson prefers to be contacted if we want to do that. And address. For a client that perhaps is experiencing some homelessness, if we don't have an address, that's fine. What is key is where the client may be couch surfing or whatever the case may be, as long as we have a good idea of where the area where they are and a zip code. That way the system can map to organizations and programs that are within pretty close geography of this client.
Jennifer, I got a question. How are you standardizing services across the network? Or I assume every provider has their own service set. And so how are you linking those?
I'll show you. The taxonomy is, we have 20 parent service types, and within or underneath those parent service types are about over 100 sub-service types, and I'll show you those in a sec. So I'm going to save client. And this is where we create the referral. If, let's say that they need, I don't know, employment. Here is where you would see all of those services. And you see benefits navigation would be a parent service type, and we have these sub-service types underneath: clothing and household goods. So this is the menu, if you will, of services that we can map to with the system. Mental behavioral health, all the way down, substance abuse, transportation. So it's pretty extensive. Does that answer your question? So I can click or type, begin to type. Yep. Employment. My challenge is typing and talking at the same time. So let's say that Jackson needs job search placement. We then have a list of potential programs and organizations that we can refer Jackson to. We recommend using the browse map functionality to be familiar with these organizations. Here is a map, and these organizations are within a 50-mile radius. This is a 50-mile radius of Jackson's zip code. We can click here and see, for example, Kansas City Workforce is the closest one. Over here, again, is where that information resides relative to program and eligibility. So if I add KC WorkSource to the referral, I'm going to add recipient, and we can then add another recipient if we wanted to do that. In many cases, if there's an emergency situation and we want to have several organizations receive that referral, we can do that and create a batch referral. And the first one that's accepted, the others drop off. We can also create an additional referral here if Jackson has additional needs, but I'm just going to go ahead and click next. Oh, and we do need a description. So now I can click next. So that referral is saved, and our next step is we're getting a request for assessment information. This is not required. These assessments are based on the service types that we select. We can just fill out a few things if we know, but I'm going to move on. So there are a number of questions that we can be able to provide information to the receiving organization about this referral and what the client is looking for. And then we have a draft referral with all of the information that we've created upon review. As long as it looks good, if we need to edit, we click this pencil here, but I'm going to submit. And here is where we are collecting that consent that the client is able to agree to share their information. As I mentioned, and that can be done by smartphone. Send them an email. If they happen to be in person, there is the capability to go to a form and download that and get their signature and then upload it. That would be here, paper form. And then audio file. And then I mentioned about attestation, which is super easy. The script would be read to the client. These are the 4 questions that they need to answer yes, 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 no. And as the case manager, as Alicia, I'm going to sign my name and attest that Jackson has agreed to share his information. And there is our referral right here for Jackson. And the organization that receives it, once they accept it, this would turn into a case, and this would be Jackson's face sheet. So that's how easy it is to receive a referral. What questions do you have?
That's great, Jennifer. Thank you.
Okay.
We probably have, we do have time for maybe one more question. Anybody in the group?
There's the reporting function that I mentioned. Aggregate data. The previous screen was for organizational data. Here's the demographic data that we are able to look at and view by gender, race, etc. We are collecting information on each of those service types, those 20 parent service types, as well as the subservice types on them. For example, over here, and here they are, those 20. If we click here, we see that 80% of our food assistance service episodes were for emergency food.
Would, in a case like Diana's, would it be possible that she indicated that they have 11 clinics that they operate? Would it be possible to say that in Clinic A, there is the dominant referral is for food assistance, and in Clinic E, the dominant referral is for housing? Is that sort of report available to the clients?
It would be, but I believe each location would have to be a separate entity in order to see that data separately. If we create one organization or one entity, the data would be there, but they would have to break that out manually. So yes, it would be there though.
Okay, thank you. Did I interrupt someone? Okay. Well, Jennifer, thank you very much. This is a very key area for us. We know it's a growing marketplace in Kansas City, that referral networks are very important to the area, and there's a lot of dynamic in the marketplace currently. So it's we're very grateful for your time to take with us and show us this. This is really a nice demonstration.
Thank you. Thanks for having me. We're really working to determine where we can best support everyone. and impact those health outcomes here. But yes, you're right. There's definitely a lot of activity. So
That's great. Well, I'd like to just take a minute before we go to open up the floor to Ron Whiting of the Kansas City Health Collaborative. He has an announcement to make of an event, important event coming up for the collaborative. Ron?
Thanks so much. Let me just turn my video on here. So I pasted into the chat a link, and it's really a good segue from what we've been talking about this morning. The Kansas City Health Collaborative is having what we call an innovation summit on the 12th. And the topic is exactly what we've been talking about in terms of social determinants of health and different models in the community and nationally for how we address it. We're also going to highlight our own work with the work groups that we've been meeting with over the last few months that include social service providers as well as clinicians, while we really try to understand this intersection of the healthcare system and social services. So on the 12th, kind of an action-packed morning, we're going to have a very brief presentation. So we're actually, I didn't count up the number of them, but there's more presentations than you might typically get in a program like this. We have different blocks. There's a block of 6 presentations in the morning that include health systems. So sort of health system, KU, St. Luke's. We have one from United Healthcare, Truman, Family Practice Group, all talking about local approaches to social determinants of health. And then we have some community-based and regional network approaches that include, for instance, Harvesters and Jewish Family Services, the MSN at Mark, and some network attempts through Children's Mercy and Wyandotte County, for instance. And then we actually have offered an opportunity for Unite Us and Healthify and Community Care Link and Aunt Bertha to provide some examples from their work, not just in Kansas City, but I've encouraged them to talk about other markets and how they have approached this real challenge of how do you integrate, unite, and coordinate services between social services and healthcare. And we have a couple of national models that we really like and want to illustrate some of the principles that we think are important moving forward. And there's one out of Columbus and one out of Albany that are different ways in which communities have come together to jointly address healthcare and social services. So I think it'll be a fun day. It's, like I said, pretty action-packed. The presentations are about 8 minutes each with some Q&A for each block. So it's fast-paced and really meant to force the presenters to really focus on their key message. So anyway, I hope you'll join us. I've pasted the invitation into the chat box. And I'd just say, the context here for the collaborative is that we think this is a really important time in Kansas City for us to figure out the right way to move forward collectively. We're going to focus on care and service delivery, coordination, collaboration, organizational structure, and the business model. And I think that business model component is, we've talked about a little bit this morning with these, but I think it's an important way of thinking about how we do this work that's sustainable so that we don't sort of repeat these unsustainable approaches to social determinants. So John, thanks for letting me talk about that, and hope
Sure,
to see
no,
you on the 12th.
It sounds like a great event. I look forward to it myself. Well, thank you, everyone. We'll look forward to seeing you next month. We have a couple of invitations out right now for presenters, and we'll announce that as soon as things get confirmed. And look forward to seeing you. Thanks so much.
thank you.
Thanks, John. Thank you, everyone.
Bye now.
Have a great day.